Good afternoon and welcome to our inaugural series of Up to the Minute in Clinical Care. My name is Barry Hoffman and I'm Associate Dean for Clinical Affairs in the College of Health Professions and Sciences. And on behalf of our college, we are pleased to launch this new series. And we want to focus on an interdisciplinary, as an interdisciplinary college, we want to develop a series that connected to our community partners to present the latest trends in interdisciplinary treatment. Today, we are very excited about the topic we have in front of us, A Voice for the Voiceless, which will highlight an interdisciplinary approach to communication in the acute care setting. Please use the question and answer time that will be held for the end of our session to have your questions answered by the panelists. You can use the chat box anytime during the session to type in your questions, and we will spend about 10 minutes towards the end to answer those. We want to thank Heather Capel and Orlando Regional Medical Center for partnering on today's presentation. I'd like to just read a little bit about our presenters and our panelists. Heather Capel is a speech clinical specialist at Orlando Regional Medical Center. She's a speech language pathologist and certified brain injury specialist with over 11 years of experience in the adult acute care and trauma population. She has been a member of Orlando Regional Medical Center's spinal cord injury team, and through which she has co-authored and was awarded the Dana and Christopher Reeves Quality of Life Grant in 2016 to support an assistive technology initiative to advance the quality of care provided to patients with spinal cord injuries and other relative diagnoses at the hospital. She has also co-authored and presented posters at the Florida Association of Speech Language Pathology and Audiologists Annual Convention and the Johns Hopkins Critical Care Rehabilitation Conference. She has presented on assistive communication initiatives for ventilated patients and other complex patient groups. Her passion is to provide quality and advanced care and communication and swallowing to all of her patients throughout their acute care journey. So we welcome Heather. I'd also like to introduce Dr. Jennifer Kent Walsh, who's a speech language pathologist, a professor of communication sciences and disorders, the director of the Florida Assistive Technology Center, Atlantic Regional Assistive Technology Demonstration Center, and the Associate Dean of Research on the College of Health Professions and Sciences at the University of Central Florida. She's been conducting research to improve language outcomes for children using augmentative and alternative communication for more than 20 years, and is currently the principal investigator for projects funded by the National Institutes of Health and the Chesley Magruder Foundation, as well as through the Florida Alliance for Assistive Technology. We're very excited that Jennifer will be joining us as a speaker and moderator. And last, I'd like to introduce Ms. Carolyn Buchanan, who is a speech language pathologist and assistive technology professional. She is the regional coordinator for the Florida Assistive Technology Demonstration Center and a clinical instructor in the University of Central Florida School of Communication Sciences and Disorders. Ms. Buchanan has more than 10 years of experience in providing assistive technology and augmentative and alternative communication services in Florida and in New Hampshire. So without further ado, we've got a lot of information to cover in the next 45, 50 minutes. Heather, I'm going to turn over to you, and we look forward to this exciting presentation. Thank you.
Thank you, Dr. Reddy. Hi, everyone. Good afternoon. As Dr. Barry Reddy mentioned, I'm Heather Capel, and I'm super excited to be with you all this afternoon and invite you into my world of my acute care world. So my goal is to introduce you to the world of augmentative and alternative communication, or otherwise known as AAC, here in the acute care setting for patients most often who have a breathing tube or artificial airways. We'll speak a little bit more and define that in just a moment, but I want to make sure you know that there is such a huge world of AAC that can be deployed for all ages and a variety of reasons and diagnoses. But today we're going to focus on one arena of AAC for the adult acute care population. AAC in this population is often transient, so necessary for a couple of days or weeks or maybe a few months. And occasionally we do have patients that require these augmentative means of communication for longer periods of time. And here in the acute care setting, we have the privilege of getting getting them aware of what's out there and introducing them to the possibilities. So I have titled this presentation, A Voice for the Voiceless, an interdisciplinary approach to communication in acute care. We'll discuss a few other professionals in the acute care environment which assist with, utilizing, can really benefit from AAC use with their patients. But interdisciplinary really speaks to every single one of us. So whether or not you have a loved one that one day might need augmentative communication, even for a short period of time, or as a medical professional, you have a patient who might need such things. We all can assist patients and people and our loved ones with communication. So here we go. I'm going to probably talk a little quicker than I'd love to because I have a good bit of content, but let's just move right on through. So before I get started, really quickly, I'm a paid full-time employee at Orlando Health, and I have no other financial or non-financial disclosures to mention. Additional notes, I will be discussing various products that I utilize within my practice. It's because what I know in my field and what works here in the hospital, but I do not have any affiliation with any of the companies who manufacture or distribute these products. So what is AAC? Per the American Speech, Language, and Hearing Association, augmentative and alternative communication, or AAC, includes all forms of communication other than oral speech, which is what I'm doing right now. They're used to express thoughts, needs, wants, and ideas. We all use AAC when we make facial expressions, or we use gestures, we have pictures or writing. Those are all different forms of AAC. But for people with pretty significant communication deficits, AAC can either supplement or completely replace their communication systems that currently just really aren't functional for them. AAC really ranges from communication boards to pretty high-tech communication devices, and it helps them to people to express themselves. So quickly, I know we have probably a pretty wide range of individuals who are tuning in today. So I want to make sure that I'm reviewing some of the terminology I'm going to mention here in a few moments. Mechanical ventilation is the use of a machine to assist someone with breathing. Intubation is when a tube is placed through the mouth or the nose and into the airway to assist someone with breathing. And you'll see that picture on the bottom left of your screen. Tracheostomy tube is a surgical creation of a hole in the neck to the airway, which through a tube is placed and allows someone assistance with breathing as well. A tracheostomy tube can be utilized with or without mechanical ventilation. You'll see that picture on the bottom right of your screen. Quick side note, I do have a lot of pictures throughout this presentation just to help with the learning and the understanding of what I'm talking about. And at the very end of the presentation, I do have a reference slide for all these pictures. Okay, so we talked about the what is AAC, so let's talk about the why. So Grossbeck et al. In 2011 describes effective communication in the intensive care unit as the ability to convey psychological and physiological needs, participate in plan of care development with the physicians and the nursing staff, and take part in end-of-life discussions, which for some of our patients is a reality. In 2011, Rathke et al. Reports that AAC enhanced patients' autonomy. It allowed for accurate transfer of information, particularly with immediate medical needs. A little sidebar here, I did have a patient that as soon as I got communication going for this patient via alternative means, the first thing he wanted to let us know was that his current proxy was his estranged wife, and that was obviously not the proxy he wanted to be in charge of his medical decisions, and he was able to very quickly change it over to the appropriate person. We were able to bring in the nursing staff and physician partners and get that changed over immediately for him. But without that communication means he would not have been able to tell us this information. Also, due to the inability to communicate, patients can report anxiety, panic, frustration, and distress, as you can imagine. Studies have found very high levels of frustration in patients who are mechanically ventilated and trying to communicate, and really not finding a significant difference in the length of time that they are on mechanical ventilation or their diagnoses in comparison to their high level of frustration. Magnus and Turkington in 2006 interviewed patients regarding their perceptions of their communication during mechanical ventilation, and their responses ranged from disheartening and lonely to terrifying, the most frustrating thing I had ever had to cope with, and feeling like being in prison. So I want you all to just for a second imagine how it must feel. One moment, everything's pretty normal in your life, or as normal as 2020 could be. And the next moment, you're in a foreign environment. All you can see is the ceiling above you. You potentially can't talk. You potentially can't move because of your injuries, or because of the weakness that you have, or maybe because you are restrained when you are intubated and potentially confused or have a lot of medications on board. Sometimes patients have to be restrained so they don't pull out vital tubes and like the intubation tube that's in place. How incredibly terrifying that is, and what a nightmare that could be. I think I just peeked out. Let's try this again. There we are. Let me get back in. Sorry, guys. There we are. Okay. So the Joint Commission, who is our accrediting body in healthcare, calls for AAC resources to be available to patients before plan of care discussions, so that they can be able to fully participate in their plan of care discussions. They call for these resources to be available at all times for the patients. Also, if there's any planned procedures that can render the patient unable to communicate naturally as we do orally after the procedure or the surgery, they call for communication system to be devised ahead of time. They also talk about creating communication kits for the different floors and nursing staff, which we've actually done here at Orlando Health. Just recently, I made a communication kit actually for our neuro ICU and our neuro step down unit, so that they had that at their fingertips when speech pathology isn't present. All right, so patient populations. There are a number of patient populations. These are just a few. It's not exhaustive, but patients who are intubated or tracheostomized, patients who have a spinal cord injury and also could be intubated or tracheostomized, patients with ALS, patients who have significant facial trauma and have their jaw wired shut. They potentially have a tracheostomy tube as a result and cannot communicate traditionally because of those reasons. Also, patients with traumatic or non-traumatic brain injuries, such as a stroke. Depending on the areas of the brain that are affected, they can have difficulties with their language or with the clarity of their speech. Considerations. So there are a lot of considerations when you're thinking about augmentative communication for a patient, especially also in the acute care setting. Patients in the acute care setting it's so variable day to day and even hour to hour. Patients' level of alertness and their awareness of what's going on around them can change moment by moment, just because of medications that are on board for the patient. Sometimes what we call waxing and waning is what we'll see, where they'll be really alert sometimes and not so alert other times. Those are things to consider. Doesn't mean that it's not important to get AAC involved for these patients for their alert moments, but sometimes it's difficult to find that sweet spot of when the patient is appropriate for you to come in and get these systems in place. Language differences, and what that means is someone who has speaks a different language. So they have a different primary language. They grow up with Spanish. Maybe they're bilingual or trilingual, or maybe they're monolingual, but it's not English. Being able to account for those language differences, patients who are in the hospital are afforded the ability to always have an interpreter, whether it's by phone or iPad or in person. But what I like to do when I deploy AAC, if possible, is I try to create a system that has their primary language on it and hopefully also English. That way, in the moment for immediate dire needs, like if they're in pain or if they're having difficulty breathing, if they point to a particular communication icon to state that they're having difficulty breathing, then the nurse or the team member who's available can immediately understand what they're saying in English as well. Language disorders can pose a significant barrier. It also could be the reason why we are initiating augmentative communication systems for a patient. Someone who can't find the right words to say, can't get the words out, a communication system might be really beneficial for these individuals. But with language disorders, sometimes we have receptive language disorders, which means the person has difficulty understanding what you're saying to them or understanding written text. Picture symbols might be more beneficial in this situation, but it definitely overall, there are things to think about when you're deploying augmentative communication systems with people with language disorders. Cognitive disorders Cognitive disorders is another area that you have to be aware of. Cognitive speaks to someone's thinking. So if someone's thinking is so impaired that they don't understand their limitations, they don't know what's happening around them, communication systems can be a little difficult to create for that population. It doesn't mean it can't happen, but it's something that you have to consider, especially the complexity of your system. When assessing somebody for communication, alternative communication means, you have to think of their motor skills. So how are they going to show you what they want to say? Are they going to be able to point to the object or point to the picture to convey a message? If they're not, how else are we going to get them to access the communication system? Visual and auditory skills. Can they see well enough, close up, far away? Can they hear well enough to have feedback if they're using a high tech communication system that has voicing? And then also color blindness, that could be a barrier as well, and something to think about. Baseline comfort with technology. If you're using high tech systems that include a lot of technology, that's important to consider. Someone with, no offense, a flip phone that hasn't been involved with technology a lot throughout their day-to-day tasks, this might be a more difficult if you're going to employ something that involves technology. So things to think about. And then family support, not the end all be all, but definitely super helpful for carryover of these communication systems. All right, so forms of AAC. There are unaided and aided forms of AAC. Unaided would be your gestures, your facial expressions, even sign language would be an unaided form of AAC. You don't need anything else in order to use these systems. Aided forms of AAC, however, you do need something else in order to deploy these systems, and we're going to get into that right now. So there are low, no tech AAC, mid tech AAC, and high tech AAC options. No low tech is just that. There's no technology involved whatsoever. It could be anything from paper and a pencil or a marker and a marker board. It could be communication boards, which you have up on your screen. On the bottom left is a communication board we use here. We have one in English and in Spanish. They might even have other languages available. This one is specific to the hospital environment, and it has things that patients might need while they're here in the acute care setting. Things, though, to think about with this communication board, while really great for some patients, if you could tell, especially on that second image, there are a lot of icons on there. And so someone who has difficulty attending to all of that busyness and being able to search through, or someone who, when they select with their finger, they aren't as accurate, having that many icons on a page, that might not be an option for some patients. So things to think about. The board that you'll see on the right-hand side is actually one that I've created on PowerPoint. PowerPoint is my go-to place to make augmentative communication, low-tech page sets. You can interchange it with anything that the patient might need, make it customizable to them, have the picture, have the written word below it, and you can make it as many icons on a page or as few of icons on a page as you need, just to get at least their immediate needs met. Alphabet boards. So there are many alphabet boards out there. There are a few here for you to see that we utilize here in the acute care setting. You have to consider how the patient is going to show you the letter that they're looking for. So are they going to use direct selection, which is touch with their finger? Are they going to have a partner to help them scan through and determine which letter they're looking for? Or are they going to really use their eyes to gaze towards the letter that they're intending to communicate? The one on the bottom left has 1 through 5 on the far left side of the communication board. This is really helpful with partner-assisted scanning. So you can go through and figure out what row the patient's intended letter is on, and then go letter by letter. So if you figure out that, yes, it is row 1, okay, is it A? Yes or no? Is it B? Yes or no? And then you go through the words like that with the patient if they cannot direct select with their fingers. The middle board is one of my favorites. It's a 4-quadrant alphabet board. And what it is it allows the patient to look up to a particular quadrant or down to a particular quadrant. And when you see their eye gaze going to that section, you have already streamlined the number of possibilities of letters that this patient's looking at. And then you can go through each one. Okay, was it A? Yeah. Okay, so what's next? And then they look in another quadrant. Okay, is it G? Is it H? Is it I? Yes, it's I. Okay. And you write down every word or every letter that they're looking at so that you have the completed message at the end. The other picture, it's not as clear, so I have one here for you, is an eye gaze alphabet board. And what this allows for is you to hold this board up between you and the patient, and it's laminated, as you can see, and the patient can then look to the different letters that they are intending to communicate. It's not, you won't always know exactly which one, but you might know that it's a field of maybe 4 or so that they're looking at by watching their eye gaze. And that is another way to utilize low tech with eye gaze. Room signage. This is one of my favorites and one that's kind of my go-to for patients here in the hospital. We spend our time with the patient to figure out what their immediate needs are. Every patient's a little bit different as to what's really, really important to them in the moment, what they're always trying to communicate with their nursing staff or their physicians or their family. We figure out usually about 6 different items or communication messages that they are constantly trying to get across. And then we'll write it on signs and place it on the opposite wall of the patient. They can then use their hand if they're able to point to the different signs around the room, or they can look at it with their eyes. And that's the importance of using maybe 6 or less communication signs around the room, because if you have too many, they get clumped together and then you don't know which one the patient is looking at. So here's an example of one of my patient's setups. As you can see, they're pretty well spaced out. There are some up above, some down below, and it makes it really obvious if they're looking up versus looking down and left and right. And you can figure out what it is, hopefully, that they're trying to communicate to you. This particular patient, good to mention, once we got all the signs and the communication messages that this patient needed to communicate, we also found out that his vision for distance was not that great. So I went in a hot pursuit for a lot of different color pieces of paper throughout the hospital. And then he decided which message would go on which color paper. That way he knew, and it made sense to him, that when he looked at the blue paper, it meant that he wanted his cooling blanket, and it made sense to him, even though he couldn't see the writing. All right, so mid-tech AAC, honestly, I do not use mid-tech AAC here in the acute care setting, but I definitely think it could be beneficial if I had it at my fingertips, but I think it's important to mention it in this presentation. Mid-tech AAC is a communication system that requires battery. It can have pre-recorded messages. You can pick the messages that are going to be verbalized as they push the different icons on these devices or on the button that you see to the far right. But we'll go ahead and move along for time purposes into high-tech AAC, which we use here in our setting as well. High-tech is something similar to smart devices. Smart devices is one type of high-tech device that can be used for augmentative and alternative communication. Your smartphones, your tablets. There are so many different applications that you can download free and that cost money to help people communicate. One thing I do want to mention is the text-to-speech option. That's really helpful, in particular for patients who have their jaw wired shut and maybe they have a tracheostomy tube and they're not yet voicing. Sometimes as patients, they're sitting there on their phone in their hospital room, but yet you still can't understand everything they're saying to you. So I'll encourage them to download a text-to-speech option so that they can then just type out what they want to say and actually have a voice. Speech generating devices. One example is a Tobii Databox iSeries device. There are so many out there. I only talk about this one because it is the one that we have here at the hospital because of a grant. This device allows us to get people communicating more spontaneously, being able to string together words and sentences and talk on a more communication, conversational type level if we get to that point with each patient. This device allows for direct selection, so a patient can use their finger and touch on the screen to communicate. They can also communicate with their eyes. So this is eye gaze capability, which is really important for a lot of our patients who are very deconditioned and weak and cannot use their hand to select what they want to say, or maybe for our patients who have spinal cord injuries and cannot move their upper extremities. It also has switch scanning capability where you use a switch and it'll go through row by row until it gets to their intended icon, although it's not something that I've utilized here. It has full Windows access. From what I understand, at least in the past, I don't know if this has changed yet, but if you are going through insurance and utilizing these devices, often I believe you have to have pay a fee to unlock the internet for internet access. But here on the acute care side, we're not dealing with insurances. We have the device here and we loan it out as the patients need it. So partner-assisted communication, I wanted to mention that here. Patients who are using AAC, sometimes, or at least a lot of the time here at the hospital, it's because they have an artificial airway and not necessarily a language problem. And so partner-assisted communication is really helpful to reduce frustration. And what it is it's anticipating what a patient wants to say by watching their hand movements or their eye movements and seeing where their targets are. If they keep missing their targets, instead of letting them get frustrated and continue to try and get the right icon, helping them to select what they're going for, their intended target. And that'll kind of help the pace of the communication to get to more natural levels and again, reduce that frustration. Speech generating devices continued. So this is our Tobii Dynavox iSeries acute care page sets that we have on our device, and it's specific to the acute care environment and has things like pain, pain severity, pain location, pain description. It has respiratory needs that the patient might need, positioning needs, orientation, and then we also have different keyboards for patients depending on what one works best for them. For those of you who have dabbled in AAC, the keyboard is definitely the most difficult interface because the icons, especially for a QWERTY keyboard, there are so many little icons that they have to be so accurate in selecting whether it's with their fingers or with their eyes. So that's definitely an advanced skill. Access methods. We talked about this a little bit. I'll breeze through it. There are the direct selection access methods that we talked about, such as touching with your finger. There also are adaptive styluses that you can use if actual finger selection is difficult with that fine motor movement. Eye gaze technology we've talked about and we do utilize here. There's also head tracking that you can use with lasers or with special optic cameras where there are little reflective dots that you can place on glasses or on the patient's forehead. We have trialed devices like that here, but that is not a device that we have consistently here. There are switch activating options for access methods. And then there's also a pneumatic switch, which we call a sip and puff, which is basically a straw that the patient can suck through or blow into to activate a command. Adaptive styluses, so we talked about that briefly. There is the caduceus, which looks kind of like a snake and it can be molded and moved. It also can be used with a universal cuff for patients where if they don't have that fine motor movement, but maybe some more gross motor movements, they can access their device or even their low-tech system easily with this. On the bottom left, you'll see a bendable stick stylus. This is one I do enjoy as well. It can be also adapted to be used as a mouse stick stylus. And then the one on the right is a traditional mouse stick stylus. A little tip is salt tips. I learned this through practice is you use a regular stylus, sometimes you'll find patients are sitting there and they're just banging their screen to try and get it to activate. But if you use a salt tip stylus, it's a bit more sensitive and it allows for easier touch, lighter touch, and activation of what they're trying to accomplish. So collaboration. In the hospital, there are so many different communication partners that a patient will have. Their friends and family, hospital staff, ranging from nurses and physicians to rehabilitation specialists, social work, dietitians, environmental, really anyone that walks into that in and out of that room. If you and I were in there and able to talk in that hospital room, anyone who walks in, you're going to say, hi, how are you? And even have that surface level conversation, which kind of makes us human. But when you're not able to vocalize like I'm doing right now to communicate and use a communication system, it takes a little bit more time. But if everyone knows it's in play, hopefully people will take that time and allow the patient to at least say hello. But then, of course, more in-depth conversations are happening with some of the other specialists, the physicians, the nurses, and the rehabilitation specialists as well. I put law enforcement on here because we definitely had situations in the past. We work at a trauma center where patients have been assaulted or shot or in an accident where it was maybe not their fault, and law enforcement will want to talk to these patients to figure out what exactly happened so they can find the perpetrators. And if the patient cannot verbalize and talk and let them know this information, AAC might be the way that they can communicate this information. Occupational therapy. So occupational therapists are my true partner in crime when it comes to augmentative and alternative communication. We work very closely with occupational therapists, me as a speech pathologist, because of their expertise and gross and fine motor skills of so a patient needs to be able to access that AAC. Occupational therapy can help us determine, can we use direct selection, maybe a stylus, maybe with the universal cuff, maybe we really need to think about eye gaze for these patients, or a combination of the two. And then obviously, like I said, positioning of the patient. If you've ever used an eye gaze device, positioning is vital, lighting is vital to get that eye gaze to work. OT and speech pathology roles are very close when it comes to our overlapping roles of evaluation and treatment of cognition or thinking. So with AAC, cognition can be addressed if you have proper AAC methods in place. Cognition can also dictate which AAC methods might be possible. On one of my screens, it looks like it's maybe not sharing. Hoping you guys can see it. Let me just check real quick. Dr. Reddy, if you can't see it, would you let me know? On my main screen, it's not showing the PowerPoint.
You're good. We see music therapy.
Gorgeous. Thank you. All right. So for music therapy, these we are fortunate enough at ORMC to have two fabulous music therapists. They are so beneficial in really looking at the whole patient, helping them cope with what is going on in their life and these abrupt changes that have happened to them. And so I definitely wanted to mention them here. Music therapy is a goal-directed process in which the therapists help to improve, help patients to improve, maintain, or restore a state of well-being, and that's per Chong et al. In 2016. For the American Music Therapy Association, music therapy is an established health profession in which music is used within a therapeutic relationship to address physical, emotional, cognitive, and social needs of an individual. We have adapted our augmentative and alternative communication systems to involve page sets, whether low tech on a communication board or high tech on our Tobii Dynavacs, to have page sets for emotions. So these things can be discussed with the music therapist, among many other things, and many other page sets that will also be utilized in music therapy sessions. Ultimately, our goal in therapy is to get someone independent with their communication. So that might mean training through AAC, because they're going to need communication means, alternative communication means, for a longer period of time, and getting them more proficient is important. It also could mean that we work towards voicing if they have a tracheostomy tube. And this is a whole other presentation, but I wanted to mention it briefly. There is a special valve. It's called a Passenger valve, or a speaking and swallowing valve, that can be placed on the end of a breathing tube for those patients who are a candidate for it. And this is a one-way valve that allows air in through the breathing tube, but then out past the mouth and the nose and the voice box to allow someone to potentially hear their voice and communicate more traditionally. Again, there's a lot of things that need to happen before this valve ever gets placed on a tracheostomy tube. And usually respiratory therapists and speech language pathologists are the ones to determine candidacy for such a valve. But that is one way to get someone back to independent communication. And then extubation and decannulation, what that basically means is removal of their breathing tubes and then restoring natural communication. So moving on to case studies, I'm going to quickly go through case study 1, and then we're going to spend a little bit more time on case study 2 before I end here today. So case study 1 is a 56-year-old female after a fall. She sustained a C1 fracture in her spine, and resulted in quadriplegia. So she was not able to move her entire body. She really didn't have much head and neck control either. She had a tracheostomy tube eventually and was on the ventilator, and would be on the ventilator for the rest of her life given the high level of her injury. So current communication for this patient was mouthing only at 50% intelligibility, actually not quite bad for mouthing. Her language and her cognition appeared to be intact, and her motor skills for augmentative communication, as I mentioned, she was not going to be able to utilize her arms and hands to be able to access communication, but she could localize with her eyes, and that way we could potentially use an eye gaze device. Her sensory and perceptual skills, so her hearing and her vision, were intact. So we deployed AAC methods of low tech, eye gaze, alphabet boards, the room signage that we talked about, so that immediate needs could always be met, whether a device was in front of her or not. and then got her training on the Tobii Dynavox I-Series device with eye gaze. She was able then to participate actively in music therapy with frequent speech pathology and music therapy co-treatment sessions. She was able to communicate more with her medical team regarding her plan of care and understanding what was going on. And ultimately, this means of communication allowed her to initiate the discussion with her family and staff regarding end-of-life decisions. When patients are on ventilators and will be on ventilators for the rest of their lives, they have the option if they want to live like that and be on the ventilator. But when someone can't communicate, that decision falls on the family. And so in this particular situation, the patient herself was able to make her needs and wants known, that she did not want to be on the ventilator for the rest of her life. And she has every right to have that, that autonomy and be able to make those decisions for herself. And we allowed her to do that. So case study 2, we're going to take a little bit more time on, not too much because we're nearing the end here, but a 35-year-old man with no significant past medical history and initial onset when he first arrived to a hospital with fever, joint pain, and ankle swelling. He was given steroids with some initial improvements, and 3 weeks later, he presented to our hospital with a multitude of symptoms: dizziness, slurred speech, really mostly unintelligible speech, blurred vision, tingling of the hands and feet, and generalized weakness. He had difficulty walking and ultimately was unable to mobilize eventually, fevers and sweating. Progressive weakness happened over the course of a month, and when he got to us after day 2, he required intubation, oral intubation for airway protection. Then we realized, or not myself, but the physician team realized that he was going to need to be on mechanical ventilation for a longer period of time. So he received the tracheostomy tube in his neck for more longer term mechanical ventilation and respiratory needs. He was ultimately diagnosed with acute disseminated encephalomyelitis, or ADEM, which is a brief but intense attack of inflammation in the brain and the spinal cord, and sometimes the optic nerves. So therapy evaluations, PT and OT came by, of course, to do their evaluations on the patient and found that, as we know, the patient was completely independent 3 weeks ago. He owned his own business. He had a whole family, a house. But when he came to us and he was evaluated, he was pretty significantly impaired from a motor standpoint, more on the right than the left, but grossly unable to move because of generally weakness and motor control issues. So the initial SLP evaluation, we saw that he was communicating via hand gestures. He actually knew the American Sign Language alphabet, so he would try to sign as accurately as he could for those people in the hospital that understood sign. Facial expressions, and then limited mouthing, but the mouthing was very difficult to understand because of his weakness that involved his mouth and the oral structures as well. His language and cognition appeared to be intact, but motor access for AAC was limited to the left side, but even in that left side, limited in the accuracy. Sensory and perceptual skills, he actually had acute visual changes for distance and double vision. He also had some auditory issues on the right, so it was better if we stood on the left-hand side. We deployed low-tech AAC options for this patient for his immediate needs, alphabet boards, the room signage, and then we got the high-tech speech generating device with eye gaze and direct selection going for this patient that we would use interchangeably. And then eventually continue to assess candidacy for that speaking valve that we talked about to get him to more normal communication means. Okay, so music therapy also came in and provided support to the patient and the family through active listening and reflective discussion, normalizing and validating the patient's feelings along with receptive music therapy. We had co-treatment sessions with OT and speech pathology, co-treatment sessions with music therapy and speech pathology. SLP, myself, also often acted as the partner and assisting the communication to help it be more fluid, happen a little bit quicker and a little easier between the music therapist and the patient when possible. We also co-facilitated a birthday party for the patient's daughter who came in while he was in the ICU, gave the patient a bit of autonomy to be able to choose what cake he wanted for his daughter, what color balloons he wanted, to try and make it as uplifting of an environment for his daughter and him to experience together during this very trying time. And then also device sharing within the hospital happened with this patient. So what I mean by that is we have one Tobii Dynavox eye gaze device for the entire hospital. Sometimes it sits on our desk and it collects dust, but other times there's multiple patients who need it at one time, and we do have to share it and have a schedule to share it between patients. And we'll talk a little bit more about that in a second, but I quickly want to get to his interview. He did agree to be videotaped and interviewed for these purposes, for educational purposes of AAC. And so these are some of his responses. What I asked of him first was, what was your communication like before AAC? I'm just going to preface this by, this is real life. So this was his response. I'll help you with that one. Go ahead.
Sucks.
It's real life. Okay. Has it been helpful to have these means of communication?
Yes, staff would listen, like when I didn't want to be suctioned.
So staff was finally able to kind of listen to you, understand what you're trying to say. And then he went on to say,
understand wishes.
Like your wishes. The staff was able to better understand his wishes. How are you able to use the device to communicate with your daughter for her birthday? You'll see me helping a little bit. That one right there, is that what you're going for? Can I help you this time? Okay.
You helped me type happy birthday, and I could tell her I love you and our things.
He went on to say, you'll see him struggling a little bit through this, so helping him so we reduce the frustration level was important. This one? Work? Okay. Is it this one? He's getting pretty good at it by this point to use the direct selection and touch, but still a little shaky. That one? Yeah?
Very before you, me kids were scared of this place.
So before me, your kids were a little scared of just the hospital and that. Well, I'm glad I could help. Okay. And then I want to show you how he used the alphabet board. So I asked him, what do you call your little girl? M, U, N, C, H, K, I, N. Munchkin. Your little munchkin. I love it. All right. And then very quick, almost done. These flowers were in this patient's room for him. And when he found out that another patient needed the device because they were in a similar situation, it really hit him hard because of the trauma really that he's gone through, not being able to communicate. He wanted to make sure this other patient knew that she wasn't alone and that he was also thinking of her and what she was going through, which is very impactful. It says a lot. And so he wanted us to give her his flowers. Obviously, we can't do that in a hospital, take something out of some patient's room, put it in another patient's room. What we did do is take a picture of the flowers and delivered the picture to the patient, which she wanted hung up on her hospital wall. And then she, through AAC and music therapy with speech pathology and music therapy, wanted to pick out her flowers to send back to him. So he knew that she was thinking about him. And this was the Google search flowers that we found and printed out those pictures as well. All right, so here are my references and my image references, and I'm going to turn this over to Dr. Kent Walsh and Carolyn Buchanan to talk about the FAST Center. Thank you.
Thank you so much, Heather. Excuse me. It was a fabulous presentation, and we really appreciated all of the illustrations of exactly how you're using AAC with your patients on a daily basis. So I'm going to have to ask you to help me and continue to advance the slides since you have control. So if you could do that. Well, we're going to make a little connection here between what's going on in the community and what's going on at UCF and how it is that we can help support people like Heather and their teams and patients and family members. So we're talking specifically today about our FAST Center, and FAST stands for the Florida Alliance for Assistive Services and Technology, definitely a mouthful. The mission of FAST is to improve quality of life for all Floridians with disabilities. And we're really looking at the advocacy and awareness to make sure that individuals across our state do have access to assistive technologies. And you saw some examples today in the acute care setting, and that they have access to services to support their functional use in the daily environment. So without someone like Heather, who's able to provide that skilled assistance in acute care, it will be a very different outcome. So those are the two kind of prongs that are most important, not just the technology, but how is it that we can support that. So I'm going to turn things over to Carolyn next, and she's going to talk about kind of the wraparound services that can be provided as patients are moving in and out of acute care, and what kind of supports can be provided both for team members and for individuals themselves, as well as their family members through our FAST Center at UCF.
Thank you. I want to start by saying that all of the services I'm about to tell you about are fully funded through the U.S. Department of Education Rehabilitative Service Administration, as well as the state of Florida's Department of Education Division on Vocational Rehabilitation. The reason I bring that up is because everything we're about to describe is completely free of charge. We don't accept any payments. We don't work with any insurances. So regardless of the person's financial status, we're able to provide everything we're about to discuss with no billing involved. There are 4 primary services that we provide here at FAST. And as Jennifer stated, all of these services are available to individuals with disabilities, family members, caregivers, as well as their providers. There's no restriction on who is eligible to receive these services. When we talk about information and assistance, we're talking about a range of things that can include referrals, funding sources, service informations, and referrals to providers. We can give this information via phone, email, in person, or via telecommunication. And this can really range. So one thing that can occur is as a patient is transitioning to outpatient care, they're going to realize how different their needs might be once they get home. So even things like realizing that the demands in their environment have shifted and all of a sudden things are much, much harder without the care of skilled providers like Heather that are there to meet all of their needs all the time. So calling up to say, I'm at home now, this has really become a challenge for me, whatever that skill is, and we can help to troubleshoot for them what resources might be available to assist them with meeting that need. We do provide trainings. Our trainings are also available to individuals themselves, any member of their support team, or providers. So we can work with them on a range of technology, which includes the full gamut of communication tools that Heather talked about, but also other types of assistive technology. So we do assist people with things like computer access, if they're coming home and they now have some change in fine motor status, for example. We're able to work with them and setting up equipment, showing them how it's used, and what adaptations might help them meet whatever their personal goals are. We do work with demonstrations. So people come often knowing that they have a need, but maybe not knowing exactly what the piece of equipment is that they want or that they feel would meet that need. We can work either on site or via telehealth. We can ship items directly to people on site and work with them on identifying what those features are, helping them to compare and contrast those different features, and hopefully help to guide them towards a decision as to what type of technology might meet their needs. Again, we also work with providers. So a demonstration in that case might be more of a discussion about, I'm seeing this patient with these types of needs. I want to conduct an evaluation or expose them to something. Can you show me what I can do for them that would meet these specific types of needs? And we do provide loans. We do have an equipment library both locally here in Orlando as well as at the state level that we have access to. This equipment can be loaned for a range of reasons. Some of the conditions and disorders that Heather talked to you about today would occur on a temporary basis, and individuals may not be inclined to go out and purchase that equipment for long-term use. In that case, we can potentially provide equipment on a short-term basis, or for individuals who want to try it out in their home setting to see if they will use it, if it works for them. Some funding sources that will fund types of assistive technology, particularly communication aids, will often require a trial period with that equipment. So we can help facilitate those trial and loan periods by setting them up with that equipment free of charge. I don't want to run over because I know we had a lot of questions, but that's a brief overview. I did include the link to our website in the chat box. If you have any question about any of those services, please reach out and we're happy to help.
Great, thanks. Well, we do have a number of questions, so we're going to jump right into them. A number of these first ones, Heather, certainly going toward you. So if multiple patients need speech generating devices or high-tech AAC devices, how do you determine and prioritize which patient in your setting receives the different devices if resources are limited?
Yeah, that's a really great question. So I mentioned low tech. Even if someone is using a high tech device, which we might have one of in the hospital, we always have some form of communication available to that patient for at least the very immediate needs, whether it's the alphabet board, the room signs, or a specialized static communication board. But when it comes to the augmentative communication device that we have one of, often what we do is when we get in those situations where we do have a couple of different patients who need it, we'll share it throughout the day. Hopefully we'll have a max of 2, and a patient will get it more so in the morning or in the afternoon. Or if we know that there are specific procedures that are coming up, or physicians are coming with the patients, or there's going to be family at a certain time there with that patient, we'll try to make sure we coordinate to get that device in the room with the patient when necessary. That's typically how we do it.
Well, another connection between our teams can be doing the borrowing right in the hospital setting as well, which is perfectly fine. We're able to provide those loans as well. So we continue to collaborate. Okay, another question. As an EMT, I often find that I run into difficulties communicating with some of my patients due to an array of medical reasons. Do you have any tips on how to communicate with patients unable to speak for short-term purposes? So during an ambulance trip, for example, and obviously with minimal tools to assist.
Absolutely. So, I'm unmuted here. I'm unmuted. Okay. Absolutely. So, in those situations, I'm sure as you experience as an EMT that the patients are usually in some sort of state of shock, potentially. They're very concerned. Also, they want to communicate things. You also might have medications on board too that can affect things, but you're probably not going to pull out an alphabet board. Probably not in those situations, but maybe. So having one on hand is good. But maybe having, what's most often needing to be expressed in those very dire emergent situations, maybe having some form of laminated so it can be easily cleaned off board that they can show you that they're having pain, or maybe a picture of a whole human body where they can show you where their pain is. But if that isn't an option, really bringing down the communication to the level of yes, no questions is sometimes very helpful. So maybe you're not going to say, tell me all the different places that your pain is and what the pain looks like and what's the severity and what's it feel like. Instead, starting to ask yes, no questions. So are you having pain? Yes or no? Okay. Is your pain up here? And, is your pain down here? And you're really getting more to yes, no questions so that those patients can at least communicate some basic things via maybe a head nod or head shake or thumbs up, thumbs down. That might be an option in the field.
Great. We also have some questions coming in the chat as well as in the Q&A. So I'm going to bring one from the chat. What do you perceive as the biggest barrier to functional application of AAC in healthcare settings?
I'll take that one. The biggest barriers that we see and that are typically reported, because we see people across the lifespan and with a variety of healthcare needs, are usually twofold. The biggest things I hear from community members are funding. These items can be very, very expensive. There can be real restrictions. We see people who come in with only private insurance available and they find out their plan will only cover AAC, for example, in the case of a total and complete laryngectomy, which may not be what they're facing. In that circumstance, they don't have necessarily the funding to help support the purchase of a system that might meet those needs. So we do work with teams to try and help find alternative funding sources and work with them on equipment and maybe lesser expensive options. But that's certainly a massive barrier when you're talking about people with significant healthcare needs. The other thing that we hear quite frequently are finding providers that are skilled on the technology that's required. So someone that can provide a comprehensive assessment, who can provide the intervention to really help guide them to be independent or as independent as possible with whatever that bit of technology is. So working on appropriate referrals, obviously some skilled providers may be inpatient, but once they get out there, we're looking for somebody who can really work with them at the level that they're functioning and bridge that gap to where they want to be.
Heather, did you want to add anything from your context?
No, I think that was perfectly said.
Okay. A broad question as well coming forth from the chat. So how do you determine when a patient is ready for AAC?
Anytime you want to communicate something and can't.
Exactly. And in the acute care setting, we've actually done some research in trying to determine that sweet spot of someone being ready who might be intubated. There's obviously, like we mentioned, a lot of variability in a patient's status because of their medication on board or other various things happening. What we look at here for those particular patient populations is we look at their Glasgow-Coma scale, and we look at their Richmond Agitation Sedation Scale, their RASS. And what we found is that the real sweet spot is finding someone who has a GCS of 11 if possible, but 10 to 11 for the Glasgow-Coma scale. And then the Richmond Agitation Scale of 0 is a good equilibrium. There's not a whole lot of agitation, and there's not a whole lot of sedation happening. And so 0 is perfect, but -1 or +1, a little bit of agitation, a little bit of sedation, while still maintaining a decent GCS, a Glasgow-Coma scale of 10 or 11, tends to be our sweet spot of, okay, let's go ahead and try and see if this patient could benefit from augmentative communication at this time.
I think it's important to remember all those different things that Heather showed us earlier. So they may not be ready for the massive eye gaze system that requires a lot of specific positioning and head and neck control. There are a lot of other AAC items and supports or communication techniques, like she was talking about with the ambulance scenario, that we could provide. The exact system might change over time as they change, but that doesn't mean we wait and hold back on a communication system in the meantime, hoping for some idealized outcome.
Okay, great. So we have a question that is a common one, I think. So how quickly do patients and families buy into the use of AAC in the hospital setting specifically? So what kinds of challenges do you encounter with families and other caregivers in the implementation of AAC, or maybe as you're introducing it?
Right, so buy-in, pretty immediate. When you cannot communicate with your loved one or your loved one cannot communicate with you, it's usually this big aha, and they're so thankful to have anything available to communicate with their loved ones. Where it gets difficult is having that communication system work with all team members in a hospital, because as you know, in a hospital, you have a different shift of nurses and nurse techs and physicians from shift to shift to shift. So you might really get someone really comfortable with this device, and then next shift comes and they might not be as comfortable. So that's where it gets a little bit difficult, is the carryover from shift to shift between medical personnel. While a lot of them really try hard, it's a new system and it's not something they use every single day. But family members, loved ones, usually they're so thankful to have something. And sometimes they're already starting the process of figuring out a way to communicate with their loved ones before we even get in there.
Great. Okay, how often do you see someone using a high-tech AAC system recover where they do not need the system anymore or can communicate without AAC independently? So we'll give
Carolyn, I'm sure you probably have something on this. Particular to the acute care environment, it's more frequent that we will have a patient utilize it for maybe a shorter term period of time while they're on mechanical ventilation or they have a tracheostomy tube and they don't have a speaking valve going. That's most often the acute care environment. But that's a very different beast than out in the community. So I think you probably speak a little bit more to that than I can.
And it ranges greatly, I would say, also between the diagnosis, the impetus for the system itself, as well as where they are in the lifespan. So we often see peds that are still developing a lot of different compensatory skills and abilities might decrease their use with a greater frequency than an adult with a more acute condition or an acquired condition or something progressive in nature. Although we do see people with, for example, a stroke who maybe do recover to a point that they feel comfortable limiting that use. So they might keep, for example, a high-tech speech generating app that they have on a phone or an iPad in a bag, but they're using it on a less frequent basis overall.
Well, it sounds like we're out of time, and there may have been a few additional questions, so we'll make sure that we can maybe connect the presenters, the panelists, to those questions and have those answered. I want to thank Heather and Carolyn and Jennifer. You're all three experts in this area, and the conversation was really, I think, forward thinking and really up to the minute in terms of the clinical tools that we can all optimize with our patients. I would like to just close out by saying this is the first of multiple clinical talks. And so please look to your email in the next week or two for a schedule of those upcoming series. We will also provide an audio of this recording of this session for you to come back and listen to or share with others that you think may be of interest. So I think we're out of time. And again, thank you to our presenters and thank you to all of our attendees for participating today.